He was trained as a cardiothoracic surgeon in England and subsequently moved to Tampa, Florida to pursue a career as a surgeon. It was in Tampa that he founded CardioStart International. The mission of CardioStart International is to educate and assist local medical personnel in providing heart surgery and cardiac services to adults and children in developing countries around the world. Dr. Marath has dedicated his life works to this mission. From Tampa, he moved to Oregon Health Science University in Portland, where he served as a teacher and surgeon. He has recruited personnel to serve in medical teams around the world, and he came in contact with Southtowne Rotarian Lauren Alexander, who was collecting surgical and medical equipment in the Eugene Springfield area. A strong partnership has been born, which has been passed down from Lauren to Don and Deborah Steele, Matt and Amanda Adams, and now Ted Stevens and myself. Dr. Marath has a unique ability to connect with the overseas medical personnel CardioStart serves. Long after his medical teams have returned home, he continues to send medical supplies and equipment to those overseas locations he has served. Southtowne is blessed to be able to support CardioStart in its witnessing, as witnessed by our upcoming container shipment to the Dominican Republic on December 4th. Dr. Marath, welcome to Southtowne. Thank you for being here, and thank you for the work that you do around the world. Dr. Marath.
Thank you, John. Christine, can you hear me?
Yes, I can. And if everybody else will mute yourself, if you haven't already, that would be great, except for
And
Dr.
if I'm
Marath.
too loud, let me know. Now, the question is whether I can connect.
We're seeing 41, number 41 of 45 slides is what we're seeing.
I've got it open, Grace. I'm hoping that'll be.
If you can
You see it or not?
Well, I'm just seeing a strip of it. They're way to.
Yes, that's right. It's strange how this has happened.
Yeah.
I'm going to stop sharing and start over and just see if I can get it going again.
Get it open to.
Shall I open to full screen? Does that make a difference?
Yes, you want to open it to full screen, but you also want to make it in slideshow mode. Start from the first slide.
Okay. Does that help?
You haven't shared it yet.
No?
Hit the square. Did you hit share screen and then select the PowerPoint?
No. I'm going to share right now and see if that.
Okay.
Remember you. It says sharing has failed to start. Please try again later.
Oh no.
Yes, I don't understand. I've got a good signal too.
I've got an idea, Dr. Marath, if you would email that slideshow to Grace, Grace can probably handle it from her end. Would that work for you, Grace?
I'll do that right now and see if that helps. I'm so
okay,
sorry.
In the meantime, I've got another couple of filler things because there's so much that we haven't gotten to. Grace has a video of Glenn's garage action, the bazaar, that she can share, but while she's busy trying to get that, juggle that incoming slideshow, I have a trivia question for you today. And this is just to kind of get you set for tomorrow's trivia game. Get ready on your chat box and chat to everyone. Make sure that it's everyone you're chatting to, because I'm going to be watching for it, because this one's really easy, really easy. And it has something to do with what's coming up sometime soon. What is Rotary's largest service project? Okay, you can stop because let's see. Nancy Meyer got it first. Good job, Nancy. And Nancy, you want to tell us all what it is, even though I think everybody else figured it out? You have to unmute yourself.
Well, polio, polio plus is, the objective is to eradicate polio worldwide. And we're down to almost, well, only 2 countries, I think, Afghanistan and Pakistan
Thank you.
are left.
Okay, looks like we're back in business. So that was a nice little stall tactic. And we'll go back to Aubyn.
Can you see the first slide?
Yes.
So Aubyn, click on slideshow right next to animations. It's at the top in the center.
Yep.
Now click on the furthest left one box where it says play from start. There you go. There you
Okay.
go.
Thank you so much. Sorry about that, Grace. We did talk on Monday, but there's never a limit to my level of incompetence.
Don't worry.
Firstly, thank you, John, for the kind introduction, Christine for the welcome, and to all of you at Rotary for the wonderful work you have done with CardioStart over the last few years. I want to make a brief mention to Nancy Hughes that I'm very much in agreement with her comments about Central America. They're devastated, but they've been devastated for several reasons, including the near emergence of martial law and police brutality and thuggery and crime in the streets, making all areas unsafe. And it's a terrible problem. And Nancy Hughes's appeal and the attitude of you at Rotary is an extremely heartening and warming experience for those people. They say that, you know, we are so grateful that you know about our misery and are prepared to still come and help us. And so I give you, you know, all our support we can offer at CardioStart. And also John and Ted already know, and Susie as well, that they have an open door to grab things that are not cardiothoracic related when they feel the need to help other mission activities that Rotary is involved in. So we have no ownership demands with CardioStart, except to say that if you can leave the cardiothoracic stuff alone, it helps us focus in the area where we have some competence. But in all other areas, you're welcome to help yourselves. So I'm going to skip the mission because John has already spoken to it, but here's a slide which shows where our volunteers have come from over the years. This is 32 years of activity, and we have people from all over the world, experts in their own centers, coming to share their goodwill and compassion. And it's a wonderful statement of the global relationship with CardioStart. The vision, again, John, you know, touched on, but this is a brief summary. Our objective is to try and give a shot in the arm to local teams struggling for the various reasons. So we listen to what they demand, and adult and pediatric cardiac surgery is essentially the major thrust, but not the only thrust of our compassionate work. We also support rural clinics where we can in relation to the hospital, because if you can increase the relationship between the primary caregivers in clinics, which are extremely deprived of equipment and personnel, and that let them have a better connection with the tertiary care unit, then we are demonstrating the importance of that relationship and that connection. As John and Ted and all of you in Rotary have learned, we collect major donations, which, you know, again, I'm extremely grateful to you for the support you have offered in this regard. And we have an efficient organizational pattern at the moment in which we can generally select things that are uniquely important to a hospital department, those that are general donations to a hospital, and those that will be useful for rural clinics. And Susie has already helped herself to items from the rural clinics, and John and Ted have already done wonderful work with the newly formed hub, which is, I think, an adjunct to St. Vincent de Paul's group, and that's local in town. So our tentacles should and can spread quite widely. Finally, orphanage assistance work is important, and it began out of the observation that many of the children we see coming for cardiac surgery were actually coming from orphanages because the parents were too poor or fractured or dissembled for them to care for the kid, and the kid ended up in an orphanage. And the orphanage has sometimes, especially when there's a religious or Christian-based orphanage, they can sometimes wrestle with the hospital administrator to give a preferential fast-tracking effect for any cardiac problems they see. So we have a lot of items that have been donated that are useful for orphanages, and we regularly give to those. And we allocate usually 2 people who are able to spend the whole 2-week period in the orphanage setting. This is just an example of the terrible problems that are being faced. Look at the bottom statement first, and you'll see that in the United States, even though our standards are very high, they're not uniform, but they are pretty good. And they're similarly in Western Europe. But we're only managing, in that collective group, we're only managing 7% of the world's population in need. The rest are struggling to emerge. And so it's a very sobering statistic and a very important one, and one that we are trying to address by setting up programs rather than just handing out donations. This is an example again of the problem we face. In terms of heart centers, there are only about 4,000, probably now 4,200 centers in the world. This slide is 2015. But the problem is that many of the centers that have established are now struggling to survive, especially after COVID, which is like a draconian monster grabbing all kinds of equipment that has to be paid for. So their frustration is enormous and worsening. But to look at the top of the slide, in a standard, one center would typically be serving about 120,000 people. In Africa, they would be serving only 33 million people, a huge difference in the number of people that are expected to be served by any one institution. In the United States, you would expect in one center to accomplish about 1,200 cases. That's a broad example. Sometimes it's much less, depending on the location we're talking about. And in Africa, you'd be lucky to get 18 cases accomplished from equipment and personnel shortcomings. In regard to the differences in healthcare provision, this slide says it all, and you can see straight away where the areas of real deprivation in deep red are, and they're regularly so. And tragically, some of these locations, such as India, have a larger number of billionaires than the United States. So it's a terrible reflection on the disparity in healthcare provision and the wealth of the location. In terms of expenditure, America has, in my opinion, been the most responsible in this regard in trying to address healthcare, even though there are major shortcomings in healthcare delivery to the individual. It has generally taken a great deal of responsibility in that and been a great example, both in intellectual work, in terms of academic excellence, and in terms of delivery of high standards. And Australia, which has got a very, very small population comparatively, and Western Europe, which is still smaller than the population of North America, they are also taking a responsible attitude. But many other countries could take a better attitude and are simply not addressing it. I hate this word third world, and I do everything I can to avoid it. And John and Ted and others know whenever we see a box with third world that some well-meaning but inappropriate person in the hospital has written on a box, we scratch it out in a fairly robust way in order to make sure we're not giving the impression that it's a them and us situation. And all these jargon phrases are, an attempt to try and describe the situation. We have chosen one for the charity called severely healthcare deprived. So it's like a catch-all phrase that we hope will catch on. One of the things that's very evident in the countries we've visited, and I personally made 100 country visits, and I've done 38 countries that we've assisted, and over 100 missions to these countries. The healthcare is always different, and there are winners and losers in this regard, and there are good and bad features in most healthcare systems. So although we agonize over the care being given in the United States where we see disparities, unfortunately, the stories are very similar in other countries. They are different causes, but they have different similar problems. In regard to what cardiac surgery does, the reason it has appealed to me to try and develop is that look at the number of specialties that are directly involved in cardiac surgical management. So when we light up a hospital with cardiac surgery, it's amazing the number of other departments that say, thank goodness you came, you've really helped us evolve. And, I can see that Susie Tanner's there in the Zoom meeting, and respiratory therapy is a very underserved but vitally important feature. And that could not have been more accurately described than this year with COVID, because the number of respiratory therapists are vastly inadequate for the number of cases trying to be managed at the moment. This is a child who was from Iran, one of the countries we visited during the embargo, sanctioned and supported by the United States Secretary, And it's an example of the fact that Washington is not always irresponsible. In fact, they can be very imaginative and supportive. But this child looks just a sad, sulky, lonely child. In fact, he has transposition of the great vessels and was inoperable because he'd come too late. He's 10. He died 6 months later because during the 2-week period we were there, we could not operate on him. But you'll notice in the by looking at his mouth, the dark hue that he has in terms of the discoloration and cyanosis, and his right hand is illustrating the fingernails that suggests massive shunting going on. And so this is one of the other tragedies of working overseas, is that we have to choose patients that have a reasonable chance of success during the 2 weeks. We do not want to leave them with a problem. We want essentially to give them a stick to help them get to the next phase of their development. And so choosing patients who are extremely end case examples can actually count against you and give you a bad reputation, which you don't want. And so we have to select the cases. So a case like this, had he presented at the beginning of the mission, might have been able to be operated on, and we would have been able to accomplish a good result. But he unfortunately came 3 days before we were due to depart. And so the sad parents, it was devastating to watch how they had to accept that he was going to die. The other issue is, when we go to the hospital, we expect there'll be a water fountain, a Coca-Cola or a sweet machine. These people will spend sometimes 2 to 3 days in the outpatient department, hoping that they can get an appointment to see the doctor. And of course, doctors themselves are massively overworked and discouraged. This is an example from Ghana, which also has a tremendous social problem of healthcare delivery. Many of the countries we are suffering from have other priorities. It's easy to criticize the Ministry of Health in these areas, but they are completely besieged with the number of problems they face. And examples here of Ebola are just one, but they require a massive injection of funds and a diversion of funds from other essential projects in order for the ministers to get the job done. And unfortunately, the Minister of Health in all the departments of a government portfolio are the ones that are changed most recently, simply because they resign. They say, I can't take this anymore. And so this is a major problem of healthcare delivery in making sure the leadership, A, is rewarded by some results that they can believe in, that they are properly financed, and thirdly, that they get the support from mission groups that we try to give. This face gives another example of the problems. In Nepal, to my surprise, we went there twice. The first occasion, unintentionally, of course, we were in the middle of the second earthquake in 2015, which devastated the hospital and fractured the elevator shaft. So people were moving ICU beds with patients in them, 6 men either side of the bed, up and down stairs to get them to various departments for their management. But there are other problems as well. To my surprise, I learned that alcoholism is a real serious problem in these rural, far-flung communities with no television or not even a radio. And unfortunately, with alcohol, men beat their wives. So the sadness on this lady's face is an example of some of the problems they face. She had mitral valve disease. She was operated on successfully, but she's wearing a coat inside the hospital during a fairly warm time, simply because it's the only coat she has, and there is no heating in the hospital. And Dhulikhel, which is part of Kathmandu, is quite a high altitude, up at 5,000 feet. So, you do get very cold at night. And these are some of the social pressures that she will return to her home and try to live with. And the devastation from earthquakes, takes no prisoners. Everybody's affected by the breakdown in the telecommunications of any kind, in transport, roads, and what have you. And so this is an example of a village that was pulverized by the earthquake in 2015. Our logistics program is already familiar to you since I've managed to drag so many of you into it, and I've been wonderfully supported by you all. Here's an example of them being unloaded, and it's such a joyous experience. We have checked each box, we've inventoried it, and we know exactly what's inside it, even if it's a multitude of different things used in ICU. But this makes a huge difference to their budget crisis. So when you get boxes of freely donated items in a particular department, it allows you to divert your funds to another department equally needed. So this is the merit of keeping this program going. I want to share with John and Ted and Susie and others who have been there is that, yes, this is in Florida, in Tampa, where we have the small house that I own and the very large yard, and we do container shipments out of there too. but it also rains whenever we have a loading day. So you'd find that amusing. But in contrast to Oregon, they're all wearing shorts because they can, whereas we'd freeze to death if we tried to do that. But they're very helpful. These are high school students helping, and it's a wonderful injection of warmth that we feel as older members of the community when young people spontaneously want to give of their time for a cause that they have really no understanding of. It's just a very, very peripheral knowledge of, but they readily want to help. Here's the warehouse on one of its tidier days in Tampa, and unfortunately it's much smaller. I've not been able to get a bigger warehouse there, but the one that we are enjoying in Eugene is thanks to the donation of the space by Mr. Steve Yett, who's a property owner here in town. This is the sort of appearance we may see when we go overseas to various countries. They are all different, and some are better than others, but they all have major deprivation issues. And, you know, they're very rudimentary. So infection is a larger problem. Recycling is a major problem. And of course, the laundry bill from having to reuse drapes is another major problem that they have to face. This is another problem. Hospitals are often old in the countries you visit, and so they haven't been upgraded from an electrical point of view. So you can imagine what a disaster this could be. This is a picture of the front end of the operating room where the anesthesiologist stands or sits. And you can see how quickly and how easily this could become a catastrophe for a patient under anesthesia if the ventilator connection or the monitor connection goes. So sometimes we are lucky enough to get a biomed to come on our mission. And if any of you know a biomed in Eugene, I'd be very grateful for you to introduce me to them. This is another example of standards assurance that we have to work on. We have to show them you can't do this. You can't have 15 or 20 syringes looking identical, poorly labeled. They must be well labeled so that you're not going to give the wrong drug to the patient. And so these are some of the standards changes that we make gently and warmly, but to encourage them to try and improve. In regard to the facilities, as you can see, this is very much the old English Nightingale ward style. It has benefits in that you can see someone crying out in pain or in trouble at one end of the ward, but its limitations are now very clearly obvious from the COVID situation that this is not an appropriate way to design a ward, and we have to live with the older wards that they are. Notice also how people are using bunk beds, because most people will have a family member sleeping with them during the time they're in hospital. That family member has to bring in food because food is not provided by the hospital to patients. So if you don't have a family relative, you're going to die in the hospital from nutritional problems. This is an example of the very best of people, and John and Ted will recognize some of the donations that this gentleman, an anesthesiologist from Los Angeles, sent up in a U-Haul trailer that I brought up further, and then Ted brought into town. This is Dr. Nosrat Kajabi, and his clinic closed, and he thought of us. He has also been on a mission with us, and he's showing the essential features of what good medical care should be. He's looking at the patient who's about to go to sleep, distracting her while he gives the injection, and the nurse is holding her hand to comfort her, making her feel less isolated, less vulnerable, and less scared. And those are the art features of anesthesia that are so important. Unfortunately, in some of the countries we visit, they forget some of these important niceties and care values in their care of patients. They get rough and they get authoritative and sometimes condescending. And they can do that to their own staff as well as to the patients. So we try to deal with that issue from the get-go in showing them that this is a very important part of care. One priority that's again neglected, unfortunately in the United States, you can get litigation issues if you don't follow it, and that is pain management. And again, they can be a little callous in some of the countries we visit in failing to give adequate care for pain. They say, well, he didn't complain, or we only have enough for 4 patients. We don't have enough for the rest. This kind of a story goes on all the time. So we do bring medications on the mission, even though we know that after we've left, that they're going to have to find some themselves. But these 2 children illustrate the ideal of what you should be looking at. A child only 3 days following an aortic valve replacement, coloring on a drawing board, and then a girl fast asleep, similar time frame, just happy and content. That's the sort of patient care you want to try and achieve. When they go out of hospital, you have to recognize and pay attention to the kind of lifestyle they have. It's not having a nice car to pick you up at the hospital, take you home to your air-conditioned unit. This is in Peru, and you can see from the example how many are struggling to get uphill after their surgery, but also at 8,000 feet. That's quite an accomplishment. There's a lot of relative hypoxia at that altitude. And this gentleman has to go back to what he does well and is the only profession he understands. And so they're carrying heavy weights going back to that. Otherwise, they simply perish. Our other educational development is in trying to help nurses and doctors achieve autonomy and complete control. So what you're seeing here on the right, lower slide, is my colleague from Chicago assisting the local surgeon do the operation. It's no use saying, watch me ride a motorcycle and then you can do it. That won't teach him anything. You have to get them back on the saddle and say, now you're going to learn the art of balance and control. The same applies in the operating room. They have to make the decisions egged on and supported so that we only take over when they're in trouble. And similarly, you see this Canadian nurse above, and she is helping the local team just pull out a central line and a pacemaker line from a baby. But the educational value is enormous. Going back to that lower slide, if you look on the right carefully, a few of you will notice that's Linda Lundeen from Portland, Oregon, who was at OHSU with me and comes down occasionally to help out the OR room. John and Ted will probably recognize if she didn't have her scrubs on. This is another picture that emphasizes the importance of the personal touch that nurses can provide. Although the child thinks that the child is just playing with the bubbles, Susan Fanner will know very clearly that there's a very important respiratory function being exercised and developed here. And that's the reason we do that post-operatively. We take these little bubbles down, they try to compete with each other to blow, and then they get a full lung exertion, and that helps them. In regard to lectures, we also give formal lectures during the 2 weeks. And what you're seeing at the top is an example of instantaneous translation, because my Spanish is very poor and some of my other language skills are also poor. And in the lower slide, you're seeing a colleague of mine at OHSU, the previous professor of ER medicine, who regularly comes on missions and teaches advanced care of the trauma patient. In Nepal, as you know, with the earthquake, we managed to get funding for some tents, temporary tents to be built for not only habitation, but also for school work for the children. And that was a tremendous assistance. Pay attention to the lower slide. One of my colleagues and board members, Dr. Emily Farkas, she's from Wisconsin. She is talking to a child we operated on in Myanmar. But notice she's clutching a doll. That doll was made by one of the church groups in Lake Oswego that I met, and their dolls have gone all over the world. They've made over 10,000 of these dolls, and we regularly get supplied with 30 for our patients. And these dolls are wonderful for the young kids because they not only have a little bonding opportunity, which as you know is of value to children, but they also hug them when they're coughing so that their wounds don't hurt. And thirdly, they have a memento to take home. And those are important features. We have obviously safety assurance and reconciliation to deal with in the hospitals. They're all very substandard. However, they don't need to be lectured, but they just need to be given a chance to help them along to get to a slightly better standard than they have in the warmest way possible without appearing dismissive or condescending. And that's an important quality that we lecture our volunteers on before they go on a mission. Remember, you're not here to sort of shout down at these people. You're here to help them get to a better place in whatever area you can. So here are examples of two groups we have. In Lake Oswego, top left of the picture are one of the dolls being made, the unisex dolls. And the bottom is a quilt made by Eugene Quilters, the wife of one of the doctors who's retired from Mackenzie Willamette, makes these with a colleague and gets material from all over Eugene and her surrounding friends and makes up these quilts or blanket covers. Training nurses is a major priority. They are unappreciated. There are too few. They work very hard. They're often ignored, abused, and yet they're vitally responsible. And this is a problem we see in American medicine and internationally, but it is worse internationally because they are regarding nurses as less important than doctors, which is absurd and inappropriate. And they have the same attitude to respiratory therapists and others. They're just there to serve me. This is not acceptable to me, and we do everything we can to try and combat that perception and make sure they are very strongly appreciated and given all the support they can. The other problem that Nancy Hughes was, almost ready to present as a comment is the major problem of law and order in these countries, that some of the countries unfortunately have very much a military presence or an oppressive presence. And this is an example in Peru, where they've had major problems with military excesses, abuses, and other issues. Where do we go next? Well, you always ask this question, and it's a totally reasonable question. Unfortunately, because of COVID, we're kind of stuck at the moment. Brazil wants us back in the rural northern areas, and the northern areas are larger than the size of many of the states of the United States. So they are also very severely deprived. The Dominican Republic can't accept us till probably March, depending on whether the levels of COVID drop, but they very much want us back. And sadly, patients are dying on the waiting list. In Ghana, Ecuador, Nepal, Nigeria, and Peru, very similar stories. And they at the moment are in a crisis situation, particularly Ecuador, which like Honduras and El Salvador and Guatemala that Nancy mentioned, they're in a state of very severe civil unrest at the moment. As you just heard, Peru has just appointed its third president, I think, this week, in as many weeks.
Doctor, I want to interrupt you just for 1 minute. It's 1 o'clock and we usually stop at this point. I don't want to stop. I see many of you are retired, but everyone isn't. So if you want to stay, please do. If you can't stay, don't worry, just slip on back to your real life. And Grace will be sending out the video of the whole program, so you won't miss a thing. So with that, Doctor, I'll turn it back over to you.
Thank you. I'm actually almost finished, but just 4 very brief slides that show some happy ending stories. This girl was one of the models in Peru. I operated on her. This slide is about 6 years old. She was wonderful in the statement she made. She says, "You saved my life, but I made a life." And that was a wonderful statement for me. And she now has married a guy from Switzerland and lives in Geneva. Good things happen to people. This young lady, 6 days post-surgery, she could not walk more than 10 yards prior to surgery, and now she has a job.
Wow.
This young lady was beaten up and abused by her husband, who said, "I'm not staying married to someone who's going to have cardiac problems for the rest of their life." She went to India, had the surgery. It was incompletely successful. We operated on her as a redo, the first one that had been done in Uganda. And she's now working for the YMCA and is remarried, and she's very happy ending. Her valve that was put in by me, but I had to use a valve that is no longer used, but is actually invented by Dr. Albert Starr in Portland, Oregon. He's a very famous heart surgeon and a winner of the Lasker Prize. Finally, this is a very important slide. This young man of 21 had severe aortic valve disease. We put a homograft in, that's a patient's valve, who had died from Nebraska in a car accident. And the gentleman to the right of the screen with the beard is a vet who came with us on the mission, and he's hugging the gentleman on to his right, who is a Viet Cong soldier, some 37 years after they had been on the opposite sides of a bridge confronting each other. And he said, "We were all fighting a silly war. Thank you for helping my son." And that's it. Finally, some of you don't think that I have a wife, but I thought I'd just share with you a picture of my wife, because she's stuck in London on COVID lockdown, and she's been with me for some 47 years. Oh, before I get to that, I know that you guys like to have little epithets and aphorisms. I thought the one from Medical Teams International was a wonderful one, and Albert Einstein's one was a particularly valuable one. But the third one is the one from Brazil, a Brazilian authoress called Cecilia Meirelles. And that is, those who hurt us but leave no scar, and there are those who simply appear and mark us forever. You Rotary people have been a wonderful shot in the arm for us, and you're a vital link to the organization's intent. And this is a picture of Christine, my wife. Christine War, you've got a namesake over in London waiting to group meeting in about 2 weeks. She's from Sri Lanka.
Beautiful.
Well, thank you very much indeed. And I'm sorry I took too long.
No, you didn't. I knew it was going to be a good program. We're so behind you, Dr. Marath. I'm really